About 20 years ago, there was a lot of discussion when comparing the results of pediatric and adult clinical trials in the population of adolescents and young adults of what makes the pediatric strategy better than adult strategy. And at that time, so many studies in Europe and in US proved that if you are treated according to pediatric trial, you may expect to have a better complete remission rate and better chance to maintain the remission. And one of the important drugs that was pointed out at that time is asparaginase. So yes, asparaginase is now part of the backbone of chemotherapy for adolescents, young adult, and adult up to I would say 60, 65 years old in induction. For elderly patients, it's more difficult to start the treatment with asparaginase, but many groups have proven that you may challenge the patient with asparaginase during consolidation phase to limit the toxicity of the drug. So I think that every adult hematologist in charge of ALL was on learning curves this last 20 years. And so we learned how to manage asparaginase, how to manage the toxicity of asparaginase, hypersensitivity, thrombosis, pancreatitis, hepatic toxicity. And now that asparaginase has widely spread into all the protocols for adolescents, young adults, and adults in general up to 60 years old. So now the question is, should we maintain asparaginase now that we have immunotherapy, for instance? I think that my opinion is that to expose the patient to blinatumomab, we have strong evidence that the MRD level before blinatumomab is predictive of what happens after blinatumomab. So it remains a strong predictors of the outcome of patients. So if you can achieve a very good MRD response in this patient, then you improve also the response to blinatumomab. You limit the risk of relapse after blinatumomab. So and the best way to achieve a very good and deep MRD response after induction is to base your induction on 4 drugs. And so I would recommend to still use asparaginase in these patients.